Welcome to This Explainer. I'm Harshal, and you are tuned in to Part 84 of Decode Healthcare. Today, we're diving straight into a totally zero-fluff, highly authoritative masterclass on ICD-10-CM Chapter 16. We're talking strict, high-stakes coding laws for the perinatal period. So if you want to bulletproof your newborn claims and completely avoid those frustrating denials, you are literally in the exact right place. We've got a tight roadmap today. We're going to breeze through four massive pillars: defining the perinatal period, exploring the perinatal lifetime and Z38 rules, sequencing birth weight versus gestational age, and finally, decoding perinatal versus congenital codes. Let's just jump right in. Starting things off with Section 1, the perinatal period, defining our timeline. Okay, so CMS is super rigid about this. By official guidelines, the perinatal period is specifically the time frame before birth running straight through the 28th day following birth. That's the window. If a condition originates right there in that specific time frame, it officially belongs to Chapter 16, which means we're dealing with P codes. But before we go any further, we absolutely have to lock in a non-negotiable rule. The CMS guidelines explicitly states, and I quote, "Codes in this chapter are never for use on the material record." Seriously, I cannot stress this enough. Chapter 16 P codes are strictly for the newborn. Never, ever put them on the mom's chart. Even if a fetal condition directly impacted the mother's care, it doesn't matter. You have to maintain an absolute firewall between those two patients. Moving on to Section 2, let's talk about the absolutes, specifically the perinatal lifetime rule and the Z38 rules. So here is a rule that honestly trips up a ton of coders. It's called the perinatal lifetime rule. You know, a lot of folks just assume that because the perinatal period officially ends at 28 days, you automatically stop using P codes on day 29, right? Actually, no, that is completely false. If a perinatal condition sticks around, you can keep right on using those Chapter 16 P codes well into the patient's childhood or even their adulthood. Like, think about bronchopulmonary dysplasia from premature birth. If your patient is 5 years old, or heck, 20 years old and still battling it, that P code stays. The origin of the condition dictates the code, not the patient's current age. Pretty wild, right? On the flip side, we have the category Z38 newborn codes. Unlike those lifetime P codes, Z38 is strictly a one-and-done deal. It indicates a live-born infant based on their place of birth and delivery type, and CMS is ruthless on this mandate. Z38 permanently locks into the principal, #1 slot for the initial birth encounter, and only that initial encounter. Say the baby gets transferred to another hospital, or maybe they go home and come back 3 days later for jaundice. You never use that Z38 code again, period. And this perfectly highlights that firewall we talked about earlier. Think of it like this. The baby's chart gets that Z38 live-born code right in slot 1, followed by any P codes. But the mom's chart? That gets a Chapter 15 obstetric code as the principal, followed by a Z37 outcome of delivery code. You just don't cross the streams. Keep them completely isolated, and you're golden. All right, Section 3, the hierarchy. Let's break down prematurity and birth weight sequencing. When you're working with Category P07, CMS does not leave room for guesswork. They mandate a very strict conditional logic. If your provider documents both the birth weight and the estimated gestational age, you absolutely do not get to pick which one goes first. You have to sequence the birth weight code, so categories P07.0 or P07.1, first, every single time. Then, right behind it, in the secondary slot, you sequence the gestational age code from categories P07.2 or P07.3. It's super simple. Weight always pulls rank over age. Just picture a claim form stack in your head right now. Right after your Z38 birth code in the primary slot, your first listed secondary code is going to be P07.03 for extremely low birth weight. Then, tucked right underneath that in slot 2, you drop in P07.22 for extreme immaturity. Because weight takes priority over immaturity, your sequencing is going to be 100% compliant. So, what happens when a newborn's issue isn't something they picked up during birth, but rather a structural malformation they actually developed in utero? That brings us to Section 4, the distinction. We need to clear up the confusion between perinatal P codes and congenital Q codes. It all boils down to etiology, the true origin of the condition. Chapter 16 P codes are strictly for acquired conditions that originate from the birth process itself or the perinatal environment. Think birth trauma, fetal distress, bacterial sepsis of the newborn. Chapter 17 Q codes, however, are totally different. Those classify congenital anomalies. We're talking about structural deformities or chromosomal abnormalities that the infant was intrinsically born with, stuff like a cleft lip, Down syndrome, or congenital septal heart defects. So remember, P codes are acquired, Q codes are structural and developmental. But what if the documentation is just murky? Suppose a baby has an infection and the doctor didn't clearly state if it was community acquired or from the birth process. Well, CMS gives us a literal tiebreaker rule for this exact scenario. The guideline explicitly says if the documentation does not indicate which it is, the default is due to the birth process and the code from Chapter 16 should be used. So when you're in doubt, you automatically default to the perinatal P code. Finally, we need to talk about perfectly healthy newborns who just need to be observed for a minute. If a totally healthy baby is evaluated for a suspected condition, like maybe maternal exposure to something, but they ultimately rule it out and the baby shows absolutely zero symptoms, you use category Z05. It's an observation code and you sequence it strictly after the Z38 birth code. But huge red flag here. You never ever use a Z05 code if the baby actually has signs or symptoms. If they're symptomatic, you code the symptoms, not the observation. And that officially wraps up our deep dive into Chapter 16. Coming up next in Part 85 of our Explainer series, we are bringing this exact same zero fluff energy to Chapter 22. We'll be decoding the absolute latest COVID-19 guidelines, specific manifestation sequencing, and emergency use coding rules. You're definitely not going to want to miss how those mesh with the rules we just covered. Until then, I want to leave you with one final thought. We've just seen how incredibly rigid this hierarchy is, from locking Z38 in the primary slot, to the strict weight over age rule, to the absolute firewall between mom and baby. Every single sequence you build tells a definitive clinical story. So, as you sit down to audit your next claim, you have to ask yourself, does my coding matrix reflect the undeniable, totally compliant truth of the medical record? Keep decoding, keep learning. I'm Harshal, and I'll catch you in the next Explainer.